Welcome to the booth. Everybody should collect at least one of those because we have birthday. Or Olympus is celebrating birthday. We're talking about 20 years of EBUS-TBNA, long time. When we started with the development of EBUS, we have had more hairs, no gray hairs, but time changed. And it's a privilege to talk to you today at the booth of the Olympus company, of the family, about the development of the technology. And it's also a pleasure to do that together with my friends, with Mike and Stefano. Mike was a believer from the beginning. Stefano didn't believe us, so it took us another 20 years to convince Mr. TBNA that he should do EBUS-TBNA, but he will tell you the story. We were able to convince him. So I don't know what I did wrong. Why Olympus asked me to talk about the old dark days when we haven't had the EBUS. So, but whatever reason, I have to talk about that. So maybe I have to provide the roadmap for Mark. So he seems to be more important than I am. So I will tell you a little bit why we developed EBUS. What was the reason why we did that more than 20, 25 years before? So my conflict, Olympus is on because I have the privilege to work with Olympus now more than 25 years. And I think together we were able to bring up a couple of good products. So what happens before 2000s? You have seen patients having a mass and having a node. And your job as pulmonologist is you have to provide the diagnosis and you have to do the staging for that patient. And why we have to do that, and these are data we have used in that age, we have to come up with the staging of the patient. And when you look even in 1997, so the 5th edition, we used at that time, the lymph node involvement was depending if the patient is suffering on an early disease or on a late disease. And that doesn't change. Even Mike just came from the next TNM staging session. It will not change. The lymph node involvement still is super dependent if the patient is suffering on early or advanced stage cancer. So the job, staging and diagnosing, was the same in the years before 2000 that it is today. So this is our target. This is a lymph node resected by the surgeon. And we have had at that time CAT scan. PET, the story of PET just started. We have had conventional TBNA, mediastinoscopy, or we can send the patient directly to surgery, and then also be getting information for the lymph node. So going to the techniques we have had at that time, first was the CAT scan, measuring the size of the lymph nodes. Everybody did that, and we know we have to do that for a lot of lymph nodes, because we knowing that we have a lot of stations, we knowing that we can measure them, but we also knew from the surgical data that we have large nodes which are still benign, and we have small nodes which are malignant. So therefore, all the committees came up, okay, you have to measure the lymph nodes. And these are the data which leads to that cutoff for the CAT scan 1 centimeter for the short axis. And you know, the decision was made based off the sensitivity and the specificity. It was just an agreement. When you say we would use the border of 15 millimeters, we have had a better specificity, but we're dropping in the sensitivity and the other way around. So therefore, the 1 centimeter was at least the agreement we did, knowing that we overstaging a couple of patients and we understaging a couple of patients when we only trusting the short axis. So therefore, these are the data. When you measure 1 centimeter, half of the patient are correct stage, quarter is understage, quarter is overstage. So this is a little bit throwing a coin, yeah? So maybe it's flip on that side or that side, half. The last publication on that was from Silvestri, and you see the negative predictive value 0.6, 0.7. So it's not really something we should trust, and we should use that as the base of the discussion how to treat those patients. So the next was PET-CT scan, and before the 2000, we only have PET, no PET-CT. So you have a PET and you have to compare it with the PET-CT scan. But when you look to the data of the guidelines in that age for the lymph nodes, this is the accuracy staging, the mediastinum. And when you look predictive value, negative predictive value, it's not 100%. We're knowing there are a lot of inflammatory disorders which creating a PET positivity in the mediastinum. We're knowing that you need the amount of tumor cells that a lesion really turns to PET positive. So the agreement was whatever we measure, we have to establish the lymph node involvement based on a cytological or histological examination. So this have been the guidelines in the early 2000s, how PET would be positioned, and it was clear you still need a tissue analysis. And there have been at that time a lot of debates regarding the different protocols, how long the patient should be stubbornness, the uptake time, the definition of the standard uptake volume. Sorry. So a lot of debates have been ongoing on that. So it was clear before 2000, we need tissue. So what technique we have had? TBNA, this is what we have. I have stolen that picture from one of Stefano's slide kits. So we have had transbronchial needle aspiration. Old technology. So Argentina, Dr. Schiperti, he invented that in 1949. They used rigid needles. And in 1969, it was shown for the first time when you use the method TBNA, you can really decide is the patient a surgical candidate or not. So the data have been out. And then I think really, Stefano hopefully is agreeing with me, Copen Wang came in the field and he developed, with the help of the MedTech, the flexible TBNA. And that really brought us then the technology where we can use the needle for the staging. So first publication 1978. In 1938, he launched the flexible TBNA. And since that time, we have had an endoscopic solution to stage the mediastinum. So the technique was there. And when you look to the evidence of TBNA, for sure, these are data which have been published years, decades before. But the sensitivity and the specificity of TBNA wasn't so bad. So the technique in your hand, used right, came up with very good data. And Stefano did a lot. Yeah? He did courses over courses to motivate the bronchoscopy world. You should do TBNA. This picture was taken on a hands-on course in Lille in the 2000. It was not a human, it was a pig, but Stefano was super enthusiastic to train you. Unfortunately, he failed because the world didn't use TBNA. There have been multiple surveys within our community. Do you use TBNA? And you look in the UK, a quarter, in the US, 10%. And when you ask the people why you don't use TBNA, oh, it's a blind procedure. I don't know where I stick my needle in. I have concerns of bleeding, complications, infection. So whatever, we have good data, but the technique was not used. No way, no causes, no chance to convince it. So I have old data with me why we as TBNA users, we never understood the concerns. This picture is from a publication in 1958. Most of you haven't been born at that time. And you see what the cardiologist did. What you see, this is a rigid scope. It's placed in the left main bronchus. This is a rigid steel needle. They insert it through the left main bronchus, injecting contrast in the left atrium. In 1958, this was the standard of care when you want to see the heart. And it was a rigid scope, a rigid needle, and nothing happens. And then the pulmonologist came, I have concerns regarding safety. So, to be honest, when you read old data, there's no real reason why we have had concerns. And even that picture I've taken from Stefano. Yeah? There are, for sure, when we're going for smaller nodes and do not have the control where we really are, we may be missing the node. So TBNA is a blind procedure. And therefore, there might be reasons why the TBNA you did in that years haven't been successful. So there was a need there. We have to have a fully controlled procedure. The other alternative have been the staging by the surgeon, mediastinoscopy. Mediastinoscopy came after TBNA. 10 years later, Carlson invented the mediastinoscopy. So it really is a younger technology than the TBNA. But when you look to mediastinoscopy, it really depends where the patient underwent that procedure. These are data comparing teaching and non-teaching hospitals. And colleagues published that in the early 2000s. If they're following the guidelines, how you should do a medicinal staging by mediastinoscopy, or if they don't follow the guidelines, and you really see in the expert center, you maybe get a proper procedure. But in most of the smaller centers, even the mediastinoscopy was not performed guideline-wise. So it means one lymph node station was biopsied and not 3 or 4 lymph node stations. So with mediastinoscopy, there have been also a problem when you compare the data of the evidence for mediastinoscopy. The data which have been published are not better than the TBNA. But TBNA, as mentioned before, was not used, so therefore it was clear we have to improve our technology. And what that means for the patients, these are data from the American Surgical Society, published in 2004, looking in the past what happens to our patients regarding staging. 40,000 patients, and this is the distribution to the stages. When we say, okay, stage 4, we don't have to do the staging of the mediastinum because we're knowing there are distant metastases. And stage 1, it's a tiny lesion. Maybe we don't need that. When you only look to the numbers, where we say nowadays we need staging of the mediastinum. I just put together stage 2 up to 3B, where the lymph nodes are involved. That in that 40,000 patients, these are 6,000 patients, and only 25% even get a staging. So that means in the early 2000s, patients were operated without the proper mediastinal staging. And that means we operate on patients who shouldn't be operated, and they may be denying the surgery in patients who they need and can be cured by a surgical procedure. So therefore, it was clear we have to change the world. So we needed that, and then we looked a little bit around. What is available? And EBUS, the endoscopic ultrasound option, was in the hands of the GI specialists since mid of the 80s. And then the idea came up, why not talking to Olympus? Can we get a scope which looks like an EO scope, but is small enough that we can use it in the airways? And then the EBUS story started. And the EBUS story didn't start with the EBUS scope. The EBUS story started with the radial probe. So therefore, here in the booth, we have 20 years of EBUS-TBNA, but we also have 25 years of the radial EBUS. But even Olympus is forgetting that. Yeah? So the radial EBUS is in the market since 1999, 25 years. So the story started with the radial EBUS. We used the probes which have been developed for the cardiologist. And then Olympus came up with the first prototypes, and these have been first prototypes of the radial EBUS. We were able to put through the working channels through the scope. When you put it in the airways, you get pictures like that. Okay, where the hell I am, what the hell I'm seeing. Because we learned, or we knew that in the airways we have the air. And the air is the enemy of the airwaves, of the ultrasound waves. So, to be honest, the first prototypes for the radial EBUS, no need for radial EBUS. But then, together with the engineers in Hachioji, we developed a little catheter, and that catheter has a water-fillable tip. And then by filling up that balloon and getting a complete contact to the bronchial wall, we were able to do the radial EBUS. This has been the probe. Nowadays, the probes are on the market. We have dedicated probes for the peripheral part, dedicated probes for the central part. And then we learned the anatomy. So see, this is a picture of the left main bronchus, descending aorta, right pulmonary artery, esophagus, lymph nodes. And then we did the first EBUS-TBNA with the help of the radial EBUS. Because you see, there is tumor, there are lymph nodes. And at that time, this was a stage procedure. So we went down with the radial EBUS. We blew up the balloon, we saw the lymph node, and then we counted the cartilage rings. So the 2 rings after the main carina, 11 o'clock, there is the lymph node. And then we have taken out the radial probe, and then we went in with the TBNA needle. So initially, EBUS-TBNA was a staged procedure. We published that in the, it's not 2033, it was 2003. This was the first publication about EBUS-TBNA, but it was not with the EBUS-TBNA scope. It was radial scope, counting the cartilage rings, which area on the clock you should put in a needle, and then we were able to do that, and you see the results. Similar to what we're doing nowadays with the EBUS-TBNA scope, but still not a fully controlled procedure. And then we decided, okay, we have to go the next level. And this is one of the famous pictures from the history where Mike, who is here, Kazu, he was at that time in Chiba in Japan. Now he's head of the surgery in Toronto. And myself met Olympus and debated the first version of EBUS-TBNA, of an EBUS-TBNA scope. So this is where the story started. There was a clinical need. We have had TBNA, good data, but not used for whatever reasons. Mediastinal surgical procedure, not properly done by most of the institutions. So there was a need to improve the access to the mediastinum. And then the story started, the development of the EBUS-TBNA scope. Unfortunately, Olympus decided I'm not allowed to tell you that story. I have to stop here. But now I hand it over to Mark, because Mark was partner from the beginning, and he gets the permission to go with you through the rest of the success story. So I wish you a nice day here in Vienna. And now this godfather of EBUS-TBNA is coming I hand it over to the presenter and he gives you the rest of the story. Have fun.